that Deb, myself, and Katie, all persons living with arthritis diseases who are attending the American College of Rheumatology or ACR Convergence, we are going to debrief on e-health, which is, oh my goodness, in 2021, it is the world of e-health. I am going to preface this though, because it's funny. Deb and I were at EULAR 2018.
Yes.
It was the first one we went to.
Yep. Amsterdam.
And we wanted to go to a session on e-health only because Orly, who is a researcher that we both know from OMERACT, Outcome Measures in Rheumatology, and also she's in the synovial tissue group at EULAR. She was presenting on e-health, and we're like, well, we're interested anyway, but we wanted the opportunity to meet her in person and kind of sneak up afterwards and be like, hey, at the end when she was done presenting. Well, I'm going to sneeze too, and I can feel it. I just feel it. So if I sneeze, I'm sorry. but hey, this is unedited, and that's how it rolls. It happens, right?
Yes.
So anyway, 2018, and it was all about how e-health will take a decade to get here, and there were people arguing against it and the reasons why it will never happen, it'll never work. And I just wanted to say that because obviously it got thrust upon us, and there nobody had a choice. But I just think it's funny that the research that was being conducted in 2018, now, fast forward 2 years, everybody was rushing to see that research.
Yeah.
Because now they're like, oh no, we got to actually do it. So
it's thrust upon us and we have no time to figure it out. So let's figure it out.
So there we go. It's just ironic to sit there at one of these conferences and to hear it was years away. And now it's here. So
and if it worked,
go ahead.
And if it would work in general.
Right. It was there were naysayers and no, that's not going to work. There's no way. And just goes to show you, just like our diseases, sometimes you don't expect something to happen, but when it does, you got to figure it out. Right. So you got to navigate the course. So Katie, why don't you lead us off with some of the information that I talked about this ACR 21 regarding e-health?
Sure. So as you mentioned, COVID kind of made things more urgent, more kind of no other choice, but let's figure this out and use e-health or telehealth. Something that I kind of wasn't aware of, but makes sense, that there are kind of security issues and patients' data record issues. And I wasn't quite following, but one of the presenters in the session mentioned the different sort of regulations, and patients at one point who needed a telehealth visit had to go to a certain spot with a secure connection, which might not have been in their home. But COVID eased some of these restrictions so that it's much more easy, much more accessible to more people to use. But then someone, I remember saying, please take this time to figure out when those restrictions come back, what platforms to use. Train your patients how to use them, what to use, what it's called, prepare for the future of telehealth, because hopefully it won't be going away. So I thought that was kind of an interesting silver lining of COVID. And another thing that didn't quite occur to me, but I'm really kind of, excited to see, is that the multidisciplinary care, where you can be, if you're in a visit with your doctor, they can also, if they've got a question maybe about your skin, talk to a dermatologist or a neurologist or any of the other specialties and have that kind of coordinated care, which is great. Not necessarily completely virtual, possibly, but using the technology to its fullest potential, which is amazing. A few other kind of points, now that there's more research coming out, how to incorporate self-assessments. Patients can do their own reporting. They can, say what is hurting, how much, how frequently, all that kind of stuff. And being able to do that ahead of time and then report in person, instead of maybe having the nurse go through the questionnaire, how are you feeling today on a scale of 1 to 10, all those things. But also how that can be both good and bad. Patients might not understand the question, or they might not do it quite accurately, or they might lie. But it's also good because it kind of, asking the patient directly, asking them, believing them, what they're saying. So that's kind of an interesting dynamic that's emerging. And then also sort of along that line, understanding and addressing any disparities in healthcare, telehealth specifically. One of the poster presentations was going into I think they called it a rapid 3 self-assessment test. And the documentation, when it was done through video or through just an audio phone call, and how when it was just a phone call, it wasn't as widely documented. And so the scores weren't recorded, and those patients who had worsening scores weren't getting as quality of care or as much care. And how that became, it was also Black people were more likely to do the phone calls, where white people were doing video calls. And that is a whole nother thing that kind of emerged. A lot of different sessions we're talking about telehealth. Is it audio only? Is it a video? And the quality through that, nonverbal cues, and being able to see your patient. And I know, Deb, you were mentioning earlier, as far as having a video conference call, even, that's got some limitations with lighting and being able to assess.
And
but
like
also
manipulating your computer, because that was what I struggled the most with, was, angling it down to, like, again, shoes and socks off and showing. And it's different. And again, you're like, if I were to put my hand up in front of the computer and for her to like see what's swollen, again, this is really interesting because I've had many different telehealth visits, and like one in particular, 30 minutes before the video call, I got a call from one of the nurses to do the rapid 3 and go through all my medications prior to where she could document that, put it in my chart. So when the doctor called me, or we went on the video chat, again, I've had so many different experiences and in so many different platforms. Because again, like each doctor seemed to have a different platform. And I know Tiffany early during—
I'm laughing because if you tuned into any of our talk show series, AI Arthritis Voices 360 talk show, we have a recurring guest, Dr. Al Kim, or Dr. Al, or just Al, as we refer to, who also happens to be my personal rheumatologist. So it did take me a while to evolve to calling him Al, but it is what it is now. So, because we have moved past even just that patient-doctor relationship, we do a lot of colleague type of work together. And again, he's part of our show. They used me a lot for testing that. So I would have a visit, and literally like 5 minutes for the visit, I'd get a call from the office going, "Hey, Tiffany, Al's going to call you, or he's going to do something. Oh, we are on your cell phone." I'm like, "Okay." And they're like, "Just answer it." So I was sort of thrust into being the testing group, which is fine. But yeah, I know that was always an issue for me in the very beginning. And I think we talked about this a little bit, I think, even in past reviews when COVID was so new, is it is different. Like every doctor was like, "Is it on Zoom? Is it on your cell phone? Is it on whatever?" You have to download this app in order to do it. Which when we talk about disparities, and that's in culture, ethnicity, age.
Right.
Asking somebody to download an app in order to meet
a 75-year-old, they're like, where do I even start? And to have the instructions, I know all the different things. It's just been a learning curve. And like one of them, I was on a platform, and I was down in the corner, and she was like 2/3 of the screen, but then there was all this wasted space. I'm like, why? Just all these things just to play with. But again, this is so interesting. And I really give them a lot of credit to actually breaking out the disparities. And, trying different things, which I think
Right.
is really good too. Great
One of-
advice.
oh,
I was
sorry.
gonna say also needing internet access and like a
Yeah.
working cell phone, and a cell phone that can
Wi-Fi.
get another app downloaded, and all those like the little things that kind of trickle down and have to be addressed, and knowing how to use something like that. I mean, it doesn't come easy to, I think, anyone really. You have to just keep learning.
Right. And then you've got some other people are cognitively impaired where they can't figure that out. And do they just get the phone call then? So it just, there's a lot of gaps that can present themselves and problems that can present themselves. Again, it's been a learning curve. It seems like every time I'd have a different one, it was a different platform or a different app that I had to download ahead of time, and instructions, like 3 pages long of instructions, and tuning in early. And one, they're like, the doctor will come as soon as she can. And like, I sat there on time and then waited like 25 minutes before the doctor popped on. And I was like, wow, that's a long time of just sitting.
Well, it's kind of like a waiting room, right?
I was gonna say,
so to speak. Yeah.
So wait, hold on. I just want to interject because I wanted to do this twice and I'm going to lose it if I don't. So before we move forward, and Katie has a few more things, a few more bullets to go to. We had a couple segments that we wanted to touch, but some of the things that Katie said overlap significantly with a couple of the other bullet points. And Katie, I know you didn't see the third bullet point, which was the can tender and swollen joints count work in a telemedicine office. But I'm writing down what you said, and it literally was what they researched. So I want to make sure before we get too far that I interject. So if you all, like, I don't know if you have pen, like I have pen and paper in front of me. Katie and Deb, if you want to like make a little note of what you wanted to circle back to, yes, that this is the time to do that. Because before we go too far, I want to make sure that I start to introduce some of the other 2 bullet points that we were going to talk about. Was the ACR, American College of Rheumatology, the conference that we're at. They have a telehealth working group that I was very honored as a representative from AR Arthritis to be the one patient that was chosen to sit on this panel to make sure that the patient voice was included. And that was to reassess existing e-health standards and make them more specific to the rheumatology e-visit community, which we know we have issues. Like we have certain things that it would be very difficult to assess on video, like Deb showed, your hands, for example. And there's been a lot that I have learned from being in there that's relevant to what Katie said. I'll just mention very quickly, like a couple of them, only because of interest of time. But know that just because we're saying this now, the conversation still continues. So we want to break out and talk more about this with you. So this is just like a taste, okay? So talking about the disparities and the video visits versus the e-health or the telehealth, and what do we call it? That was super interesting. You said that because that was one of the first questions that came up in this working group. Do we call it like, what is telehealth? So we had to define that was going to include telephone and video, even though it says telehealth, but in our standards, we had to create some sort of definition. And they were also talking about different cultures, different ethnicity groups, more comfortable on the phone versus a video. So we have to think about that as well. And how do we overcome those challenges, especially when there's a lot of visual? And as you said, Katie, research is showing there could be better outcomes for those who are using video. So they're putting it on the table. It's an early thing that we all still have to work through. Come a long way since 2018, if you are, but still a lot to work through. The other thing that I'm just going to throw out there that I found fascinating in the work that I've been doing with them, because I get to listen to the rheumatologist. I was the only patient, so I got to listen. And then there was one rheumatology fellow, and then the other 9 or 10 were rheumatologists. So I'm listening to their perspectives raw and as they're experiencing this, and to hear them talk about their own challenges and exciting benefits that they're finding with video and having these telehealth would be the the significant others or the family members being at the visit.
Oh, good point.
And being able to see somebody's house, see their socioeconomic factors that you don't really know when somebody comes into an office. You get to see how they live or how people are conversing in the back, or, you know, they're like, sometimes you see things you really wish you didn't see, but that's reality, you know, and a real eye-opening moment. So there's a lot to the video as opposed to the phone that
Absolutely.
could add to that. So again, we could talk about this seriously for hours, but in the interest of time, I want to move forward. So Katie, to add to what you said, which was, I wrote it down here, that, you know, patients could do more with reporting and questionnaires and beforehand. And Deb, you even said that you were asked to do a few of those.
Right.
And Katie, you mentioned issues. Maybe they don't do it accurately. Patients, will they believe me? Which I kind of smiled, because when I was reviewing the research that I'm going to mention now, I was asking those same questions. So
Right.
Deb and I looked into it was an abstract, and the difference between an abstract and a session. So, you know, if you're looking at this video in the back, this would be a session. Deb's in an empty session. They've all left. But
It's virtual.
the session, it would be a room with a lot of people in it, and you walk in and they're lecturing, they're talking to you. It's not interactive in any way. Whereas an abstract would be, and if I had that background loaded, I just flip it over and show you, but I don't. So it's like a sea of big posters, and those posters are a summary of the research that was conducted. So it's all on this one poster, and there's just rows and rows of them. And what'll happen is, in these sessions that you would see, they will talk about the research and often reference some abstracts or the posters you would see in the hall. So in this case, the reference, it was called "Can Tender and Swelling Joint Counts Work in a Telemedicine World?" And I think we've answered a lot of those just talking about it. But I know, Deb, you mentioned it. So Katie, let me ask you, have you had to do joint counts or anything like that so far? I mean, you had to have, or something. You had to have met with your doctor. Did they do anything like how did they look at your hands on virtual care?
The only telehealth appointment I had, I only was able to have one, and it was through a phone call. And it was before my surgery. I was in bad shape. I think my rheumatologist kind of knew that. So she's like, you know, any changes, any concerns? But I think it was like a 5-minute phone call, just like, things are the way they are still.
Okay.
Pretty much. And then that was it. So
all right. Well,
nothing beforehand, nothing, you know, pre-assessment. So, I mean, Deb, you're saying all these different things. I'm like, I just had one phone call. I asked for a telehealth appointment again, but they said, no, we're not doing that anymore. So I didn't even have, but that was later on. So
sorry, I'm reacting.
Experience.
I know, I'm reacting too. There's so many questions. Okay, but all right, we're going to have to circle back to that after the debrief, so we can focus on the research, but we're going to have to get into more of that.
I will mention this in another session, and I can't remember, I think it was about coding, and they're talking about even email questions now are getting billed for, or starting to. Yeah, so that was something that, you know.
Okay, so this is a bill. Okay, so well, there were actually a lot of sessions that we did not go to because we're not physicians. But I can tell you that there are a lot of public policy, legislative work that's going specifically with doctors advocating, because with fighting with providers, healthcare systems, et cetera, to not be reimbursed for their time if it's telehealth or emails or what constitutes that. Yeah. So there is a big gray area there. Just for patients, if you're the ones, our primary audience here, just know that's all part of that. Well, my experience was, I have spondyloarthritis, so that's primarily of the spine, and I had the worst, I thought, flare. I didn't know, and that was the whole point. It was so tender in my kind of mid-low back, which isn't my normal spot, and so it was painful to the touch. It just, the skin hurt. I just couldn't figure it out, and and my husband was looking at it going, oh my gosh, it's all swollen. So I'm backing up to the video camera with Al. Can you see it?
Yeah.
Going like this, and he's looking in, and so I mean that's one of those situations where you're like, how do you tell really what's swollen, what's not, what, it's just difficult. So the study,
it's subjective, really.
it is, and that's
Bad
why
lighting.
that's why this study caught my eye so much. And again, I'm going to just briefly talk about it because we're spending a lot of time on this first topic. I don't know if we'll get to the third topic, but it was really fascinating. So there was a group, it was a Canadian in Canada, Canadian study, and I do actually know one of the researchers, which is why I'm going to not spend as much time as I normally would, like breaking this down, because I have questions and we know somebody on the team. So
awesome.
I'm going to get some, I'm going to follow
go
up.
To the source. Yeah.
Go to the source. Exactly. So they're asking a question, with virtual health, essentially, could patients do their own joint counts? Will it work? And if you've ever been in a rheumatologist's office, they have those, you've seen the forms, you get it, it's called a CDI, which is a study, the doctor fills out the joint counts. It's got those big, scary person with the hands like this.
Yeah.
They're like big, gigantic hands. And then there's a global assessment. Yeah. And so they're all called, so there are all these, areas with the really big hands, because it was specifically originally designed for rheumatoid arthritis, which is why they, it's got such a focus on hands. Anyway, and then there's a global assessment. So you'll say, on a scale of 0 to 10, how are you, this week or whatever. And then the doctor will give a global assessment to add it up, and that's your total. That's your number. One of the tests. But the point was, this was to assess rheumatoid arthritis specifically, because that does tend to have a lot of the swelling in the joints. And this is kind of the earliest, can we do this? So whenever you do research, the thing to note is you have to start somewhere. And the somewhere should always be with a sample, which would mean the people who are being studied, should be at least somewhat of a synonymous group. So they have something in common, so that there's a baseline, a start line that can be measured. So that's why they don't start with just a mismatch of all these people, because there's, especially when it's the first level, the first step of research. I did find it interesting that it's early arthritis. So the people in the study of 937 were people who only had disease for less than a year.
Wow. Yeah.
That initially caught my attention because I had all these questions, which I have to ask them, I have to follow up on. Well, why did you pick the early? I think it's because of the baseline, but then it leads me to all of these other questions. Was it because they're not biased yet? They don't, or maybe, they're not gonna, well, nobody can tell me what this hurts and what this doesn't, or is it because they may be less likely to have swollen joints? Because my first question before I saw the time frame was, well, how the heck could you really be able to feel like a doctor feels that fluid or whatever? And that's not as common in early 1-year onset rheumatoid arthritis unless you have very severe onset, right? So I thought that might make sense, is why they got to start somewhere. But I don't know that for sure. That's my own theory. But bottom line is they asked the doctor, and I'm also unclear of this, maybe you saw it, Deb, but I looked, it scoured, and I couldn't find the answer. They had the doctor and the patient both perform that test, the one with the big hands and the global assessment. And for the most part, they were similar. They're like, oh, good. What I didn't understand is, were they in person? Like, did the patient go in one room and the doctor go in the other? Was it the exact same time? Because our diseases flare, they change, the doctor had to assess them in person, right? Because that was the study. They assess them or did the doctor assess them on the camera?
Or if it's like this, I'm holding my hand up and this is my right hand. And
you touch that? couldn't catch, I didn't see that.
No, it didn't.
Okay.
It didn't like clarify any of that type of stuff. And again, that's all really important because, you know, give them instructions because like, I know when, even with my hands, which are 38 years into this, and they're like, oh, well, that may look big, but it's bony deformity. It's not the swelling. So yeah, so that's
early.
Right.
So,
yeah.
So that's why I'm looking at this when we have to look at this. So if you're a person
Yes.
who doesn't say, well, you know, it's not relevant to me, it is. They have to start with a baseline. You got to start with something. And you would think, and usually that's actually why rheumatoid arthritis is typically the one, if you're like, they always get the studies. Well, it's because it's the easiest one to study. It has a lot of the clinical guidance already there. It's more widely spread. More people can be in the trials. There's
Right.
a lot of reasons. It's less complex than, say, lupus.
Right.
You know, so that's why it's often picked. Anyway, I wasn't clear. And if it was that they're doing it virtually, because this is e-health, and
Right.
the doctor and the patients had more of the same results, I would be interested in then having the same day the patient go in and see the doctor and see if the doctor had the same responses. Because then you would be able to see, did they see it correctly or were they
same day, same time? Yes.
Right. Like that would have been like, oh. So I am curious a little bit more about that. And if that would be planned for, say, phase 2 or, you know, I think that would be an interesting, at least observation for the doctor to
Right.
say, oh, I thought it was this, but then I saw it in person and it was this.
And felt it and actually saw that, oh, it was you know, it looks swollen, but it's actually, you know, something else. Or I mistook that the lighting was off. And there's so many different
so
things.
let me ask this question. Again, there's a lot we can expand on this, and we just don't have time today, but we can do that in continued conversations, and we will do that in continued conversations.
Right.
I will present more of the information. You just got to come and tune back with us. See, that's how this is going to work. And saying that, I have a question. I have a question for Deb. I have a question for Katie, and I know my answer already. And I have a question for patients out there. What do you think about this? If you were asked to give your own assessment.
Yeah, it's like how much training did the patient get as far as what to look for? Or is it basically on pain scale or discomfort?
That's a good, I know the answer to that because they did a second, they referenced a second study. Katie, how would you feel if they asked you to do it?
I would do it if asked, but I don't think I'd be confident in my responses because I know that I downplay it a lot. My rheumatologist always tells me to complain more. So I know that it would probably be a lot higher, and then maybe I try to overcompensate or undercompensate. So I would just prefer to have someone, you know, more familiar, more trained, probably
do it.
Yeah.
Yeah. But again,
I also wondered how that, I just would love to see if there was a survey done, a qualitative survey done with the people in the study. These were people with early RA. So I would feel like they have more questions than somebody experienced. And how does that play in to it? Like I have a lot, this led me literally, I think 2 hours of my day. I couldn't stop looking into it because it just fascinated me.
Rabbit hole.
It really did. It put me in a rabbit hole because I just kept going and tracking all the research done.
Yeah.
But the question about pain, the one thing that they did assess, because they realized patients who had widespread pain, which often people will say that could be comorbidity of fibromyalgia, but those were harder to match than somebody with localized, which sort of makes sense. If you have pain here, 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 and here, but you also have pain here, then I would think that would be harder to pinpoint, you know, so that logically makes sense. And you may say, well, why did they have to study that? Well, sometimes you also have to study things that may seem obvious to get the data. You can't just say, oh, well, we think that this is, you have to have the concrete data to build on. So
Right.
I'm glad that they did that. But Deb, I think I cut you off, but I'm sorry, you were going to say something else.
No, it is very interesting. Again, you could go down so many different rabbit holes talking about this. Again, early RA versus later RA and, intermediate RA. It's very subjective. And like Katie says, even if like I'm not feeling pain in this joint, but there's swelling there that they notice. Because again, they use like dark shading, they do circles around if it's just swelling and things like that as far as documenting it. It's just really interesting.
Well, I know that they asked them to assess pain and swelling. There were two different assessments.
Right.
Again, I don't know. I keep I know with myself, and I'm thinking early. I'm thinking my mentality early. I feel like I wanted to be believed so bad that I would just, even if it just barely tingy hurt, I'd be like, well, this one hurts, or it's just, I think that mental whole path to get to the diagnosis,
how long that
has to play into this as well. So I feel I was left with more questions than answers, but that's not a bad thing.
Right.
That there's a lot more that we can do with this one. But I want to move back to Katie, but I wanted to ask you both if you had anything else with this study in particular, but I am going to follow up, and we will do, for the first time, I think ever, debrief part B.
No, I'm actually anxious to hear the answers, and then that'll probably create 10 more questions. So,
what I'm going to try to do is get the researcher that we know.
Right. Yeah. Which is perfect.
Possibly to come back and talk with us.
Oh, no, I'd love that. Yeah, that'd be fascinating.
So, okay, Katie, there were a couple other things with e-health. We went way longer than we thought on e-health, but clearly it's an in-demand topic.
I'll just point out a few more things. One of the other things, one of the physicians kind of like a mini rant was people maybe not taking their telehealth appointments too seriously. And they mentioned one of their patients was on a bus doing their visit, and how that is fairly inappropriate. It's not secure. It's not, they're not focused.
Yeah,
exactly. And I can see it from the patient point of view. Maybe they need to get to their job. Maybe they're going to their daycare. Needs come up, but also, that opens up a whole new realm of things to consider. Are you driving?
Sure.
Could you get into a car crash because you're talking to your doctor? It's just,
I did hear doctors. I have heard doctors talk about that specifically. That there are a few of them have started to ask that the person who is calling is not driving.
Is it safe to talk?
So it reminds me of those signs. Like you see these signs that look like a person getting squashed in between like a bulldozer or something. You're like, what? And that had to have happened at some point to make that sign. So it's one of those
more than once. Yeah, it's gotta happen more than once.
I kind of feel like that's what's happening. It's like, okay, we kind of did it, and now wait a minute, we've got to have these warning signs like do not do e-health visit in the car, on a bus,
I just remember even texting and walking, because people will walk into people all the time and walk into a street and not realize, again, you're so into doing what you're doing.
Or being on your phone in Amsterdam and almost getting ran over by a bicycle.
Which one was it? I was going to say, that's too specific for it not to happen to one of you.
Yeah. And again, the bicyclist just going off on a rant, because they said, what is it? It's bicycles, walking,
cars. That's the order of the road. So bicyclists rule the road, then pedestrians, then cars. Yeah. And so it was our first or second day there, and Deb's in her phone doing something, and she's all of a sudden you hear, get out of the way. I'm like, because I thought she was I was ready to die and save her.
Just crazy.
Okay, sorry, we digress. But that was at UR. That was at UR.
Yeah.
2022.
Always a good time at conferences.
So anyway,
and then one more kind of note as far as COVID and isolation. There was a poster from a patient. Her name was Ida. She said that the telehealth visits offered connection, and when she felt really isolated during the shutdown, being able to still get her, care was very helpful to her. But then another couple abstracts talked about how mental health needs increased, and isolation, specifically among rheumatic patients, also increased, and telehealth visits resulted in fewer referrals for mental health services. So an interesting kind of, they did help, but maybe not enough. So another kind of facet to consider. ...
on this subject. It's just, it's
more to come.
We also should, as we wrap up this, we should also circle back to Orly.
Oh yeah,
we
absolutely.
started with this, talking about this when we know she did research. She was one of the people, in the panel, and we did have her back in 2019. No, 2020. I can't remember. One of the World Arthritis days when we were doing interviews, we had her back to talk about e-health. And then we also had, ironically, Lisa Zucker, shout out, from Washington University, who was part of the session that Katie was talking about, that I'm also part of the telehealth group. So that kind of all circles around. We need to ask all three of them, because they all have been on our show, on our talk show on e-health. So,
in specific, and again, before it just took off like a bat out of heck.
Oh, and as we're closing this one segment off, and we'll move on to the next one, I want to take this opportunity, and I'm going to date this, that this is November 2021, so this opportunity may change, but our organization was also asked by Washington University, and Lisa being the lead researcher on this, she did receive a grant from the Rheumatology Research Foundation, which is through the ACR, to start creating guidance for shared decision-making practices in rheumatology. So between the rheumatologist and the patient, and it's expanding on this whole e-health. So it's in e-health, but it's shared decision-making when you're not in the office. And we have done a lot of work in this space in our organization. I sit on the shared decision-making team at OMREC. Deb is also participant in that working group. So we have a lot of knowledge on the topic. So we're very excited that we were picked as the patient organization to do that. And then also as a professional focus group moderator, I was also asked to be one of the focus group moderators for assessing how patients think about e-health and how we can start building this model for shared decision-making. I'm saying this because we are recruiting right now. Katie saw it. I just got the email. It is November 2021. We are going to start doing focus groups in December of 2021. So anyone with the rheumatic disease, we are looking for you to sign up. You can sign up at our aiarthritis.org/AIarthritis Voices. That's where our applications are. When you fill out the application, it just takes a few minutes. There's going to be a space near the bottom that says, if you heard of any specific projects or opportunities, let us know. Type in the shared decision-making project, WashU project, and we'll know exactly what you're talking about. So there we go. There's e-health, and that project will go on for a year plus. So it's just depending on where we turned in. So Katie, was there anything else to add for e-health? Or are we wrapping that segment up?
I think there's a lot more to add, but not right now.
Okay.
To be continued.
Yes.
To be continued.